Um, yeah, thank you so much. It's been such a such a real honor and privilege to be able to do this series with you, and I'm so thankful for all the participation that we've had. I think it's very fitting that we are wrapping up this series on honoring neurodiversity through affirming healthcare. And I am so privileged to have my co-faculty with Len, Ahia with us today, and we will both, she'll introduce herself a little bit more here in a couple of slides. We have no financial disclosures. We wanted to start off with a positionality statement for each of us. So I will reintroduce myself. I'm Erika Phelps-Nishiguchi. I'm a developmental behavioral pediatrician. And I think it's important that you all know that I'm coming from a non-disabled position. I don't have any disabilities myself. I am white, and everything that I've learned about disability has been through the medical model, going through um, medical school and residency training, and then fellowship training in developmental behavioral pediatrics. I do have three first cousins who have developmental and behavioral disorders. I spent time with them a lot when we were children, but less so in adulthood. And not really since being in this field. And so I don't have that lived experience really to draw on. And on the cultural side, I am not Hawaiian and I don't have Indigenous roots. I did grow up in rural communities, and that is a big part of my position and identity. So I'll step over and let Mahea introduce herself.
Aloha mai kako. I'm Mahealani Ahia, Mahea for short. I am a Kanaka Maoli. Maui is my home. I am currently a PhD candidate at UH Manoa, finishing up my dissertation at Yale University, zooming in. I teach Indigenous Pacific literatures and feminist theory. I do all of my work in honor of the memory of my daughter, Hina Aina Meleonalani, who was born with congenital disabilities and passed away before her third birthday. So all of my work in disability studies comes in honoring her, as well as having chronic health issues myself, which places me in disability sections also. I am a LEND faculty. I was a trainee before, and I am here offering modules on cultural humility and place-based learning because we recognize the different persistent disparities among children with developmental disabilities, like my own daughter, especially from rural communities. And so all of my interdisciplinary work goes to working on intercultural competence and humility. Mahalo.
Thank you so much for that beautiful introduction. I think this is our, I guess, Mahea, I'll let you take it over from here and I'll step back in a few slides.
So at the conclusion of our activity, we hope that our participants will be able to describe how Hawaii's culture and history affect perspectives on disability, neurodiversity, and mental health, to recognize our cultural depth of naming practices and self-identification, to define neurodiversity in the social versus medical models of disability, and to learn how to incorporate cultural and neurodiversity affirming practices into your clinical practices. So today's path, we will be starting with disability in Hawaii and then moving on to some different models of disability, neurodiversity paradigms, and then our practical steps. And we've got a couple of short videos for you to watch in between there. So starting with our cultural terms, we need to acknowledge first off that there is no actual word for disability in the Hawaiian language. We consider all bodies and forms of life to be full of value. The word kino is our word for body or form. And the closest word we might find to a form of disability would be e'epa. So e'epa is a really capacious term that means special, extraordinary, incomprehensible. It has kind of a miraculous feeling to it, including miraculous mana, which is our forms of power, which is spiritual, social, economic, all different kinds of power. It has this sense of the wonder It has a kind of a gloss sometimes of trickery or deception. And those are like kolohe or mischievous kind of words. One of our other Pacific cousins, the Chamorro word from Guahan or Guam is dakon. So they have some similar language. Other types of language we might find is the Kino E'epa, which is like a spirit body or maybe a strange form. We sometimes use or find EHEPA, which is someone, it says behaves foolishly, but what it is it's someone in their own realm, in their own world, moving in a way that is maybe not normative. There are also some other words like kina, which has to do with disfigurement or physical defects, and the Chamorro word for that is kayao. Some of the most important words that concepts we're looking at are pilina. So our relationality in a Hawaiian context or really any of our Pacific relations have to do with pilina, that which sticks or is connected to, and that includes to the lands, to humans, and to non-humans, particularly our families and our kaya ulu, which is our communities that help care for us. So I work with storytelling for healing, and so mo'olelo or stories are very important to me. We find in our kino, in our bodies, lots of ancient stories that have to do with strange forms. So sometimes babies are born resembling a fish or shark or rock or lizard. We have stories of kupua, who are wondrous characters who are born in the form of a rope. Hi'iake Kapoleo Pele is the volcano and fire goddess Pele's youngest sister, who she carries around in the form of an egg. So we have all these different types of body forms that are recognized and beloved. One of our most powerful identity stories is that of the taro plant, the kalo. And so Wakea, who is the sky father, and Hohoku Kalani, which is the word for our expanse of the stars, they mate and have a child who is stillborn, and they name it Haloa Nakalau Kapalili, which is sort of like the stalk that flutters in the wind. And they take the stillborn baby and plant it at the east side of the house. And when it grows, it transforms into the first kalo plant. And so we have this Pepe E'epa, this wondrous baby from the first family. Now they go on to have a second child who they also name Haloa, which is considered the first Kanaka, the first Hawaiian child. And then we see a relationship, a pilina of reciprocity here. So the kalo plant is said to feed the younger sibling, Haloa, and Haloa, as the younger, serves the kalo plant in taking care of it. And we have a reciprocal, both environmental and relational story here. And we see this kinds of shape shifting and noticing how the epa or the forms, the different body forms, are valued members of our community. And so not only our fantastic stories in Hawaii, but also our chiefly stories tell of different institutions and policies that have been created to care for those with physical, mental, developmental disabilities. One of these particular places was created is called the Waimano Home. It was originally titled the Waimano Home for the Feeble-Minded. It was established in 1919 and was a residential hospital for those with developmental issues. It was closed in 1999, but while it was still under the territorial government of Hawaii, there was a board of institutions that oversaw multiple locations that housed those with both mental and physical disabilities. And sometimes these inmates were transferred between them, between the Waimano Home and the Hawaii State Hospital, which was the asylum in Kaneohe, and even into the carceral system. So we saw various different institutions taking care of those and finding homes for them. And we wanted to share a short video by Auntie Puanani Burgess. So she's someone whose memory is very dear to me. She was a late Hawaiian educator, poet, and advocate. And she created a short film called A Boy with a Gift.
Are you still seeing my screen?
Yes, perfect.
Okay, perfect. Tap volume here.
Simplest form, it refers to a community where you are beloved. What is a beloved community? In its simplest form, it refers to a community where you are beloved. A place where you can be yourself, thrive, and help others around you grow as well. Auntie Puanani Burgess is a Kupuna, culture facilitator, storyteller, and the creator of a ceremony called Building a Beloved Community, which uses traditional oral Hawaiian storytelling to lay the foundations for beloved communities. For my senior project, I animated the story Boy with a Gift to share the story that everyone has a gift. Even if you feel like you don't have one, you do. I present Boy with a Gift. Enjoy.
Aloha, Michelle. You know, in the work that I do in building the beloved community, there's a process I use which involves asking people 3 stories to tell. First is to tell the story of all of your names. And when you tell that story, you tell the story of your people and your family. The second story is to tell the story of your community, where you come from, and how that makes you feel. The third is to tell the story of your gift. That often is the hardest story to tell because it requires you to dig deep and to really honor something that is inherent in you that oftentimes is not seen by others. I did this story with a group of 11th and 12th graders at Waianae High School, young women and young men. We sat in a circle and we went around the circle, and each one of them told their 3 stories, their name, their community, and their gift. Until we got to this one young guy when it was his turn to tell his stories. He told the story of his name and his community, but when it came time to tell the story of his gift, he pushed back against me hard, and he looked at me straight in the eye and he said, "Miss, what kind of gift you think I get? I stay in this freaking special ed class. I get hard time read, and math hard for me. And why you make me shameful? Ask me the kind of question, what's your gift? If I had gift, you think I'd be here?" So he just shut up and he shut down. And I felt shame because I made him shame. So I shut up and I shut down. Fortunately, in every community, there are always places where you can see everybody you like see and everybody you know like see. And so in Waianae, one of those places for us is Tamora Store. So I'm in Tamora Store and I'm pushing my wagon down the aisle and I see that boy and his back is faced toward me and all I can think of is run. And so I start to back up and I'm trying not to hit anything on the side and trying not to make any noise because I don't want him to turn around. I don't want him to yell at me and I don't want him to make me shame again. So I'm backing up and then he turns around and he looks at me straight in the eye and he says, "Auntie, I've been thinking about you, you know. I've been thinking what my gift. That auntie told me I gonna give, you know, so I better find him. So auntie, I've been thinking about it, you know." So I looked up at him and I said, "So brother, what is your gift?" He said, "You know, I get hard time read and math hard for me. But auntie, when I go in the ocean, I can call the fish, you know. And a fish, he come every time. Every time I can put food on my family table. And sometimes when I stay in the water, the shark, he come, you know, and he look at me. And I look at him and I tell him, "Uncle, I'm not going to take plenty fish. I'm going to take 1, 2 fish just for my family. All the rest, I leave for you." So the shark, he tell me, "Are you cool, brother?" And I tell him, "Uncle, you cool." And so the shark, he go his way, you know, auntie, and I go my way. I look at that boy and I think, you are invisible to them. They don't know the quality of your mind and your heart and your knowledge, your Ike. And I think to myself, how do we make room for the gifts of all of our children? And how do we make these schools really be attentive to and begin to see and teach to the gifts of our children? but it begins with each one of us thinking about and knowing that we have gifts and having the patience to wait for the answer. So my question to you is, what do you bring to your community? What is your gift? Mahalo.
So we just wanted to prompt you to think about a few things. What is disability? What makes a condition disabling? And have you heard of the terms neurodiversity or neurodivergence? And then we put a few more questions to you. What might Indigenous perspectives offer? How might we integrate Hawaiian perspectives more intentionally and thoroughly in our individual and collective practices?
Thank you so much for taking time to prime your brain for thinking about how we conceptualize disability. I think that's a beautiful story to help us really get into the essence of today's discussion. We'll spend the next couple of minutes diving into frameworks for thinking about disability. So, in particularly developmental disabilities in which the brain and the mind are affected. A disability, as its etymology suggests, means impaired function or ability. There's many different definitions for disability, and the World Health Organization defines disability as occurring at 3 levels. The first is an impairment in the body or brain function or structure. And 2 is that this impairment then leads to a limitation in ability, such as the ability to read or the ability to move one's body around. And then the third level is a restriction in participation, such as exclusion from school or from work. However, the impairments and the limitations can be seen through different models or frameworks. There are several different models, but the 2 most prevalent that we think are important for you all to know and understand are the medical and the social model. The medical model of disability is probably the model with which most of you are familiar. In the medical model, the disability is caused by a pathological defect within the individual. The problem, as those arrows are showing, is in the individual themselves. Something is wrong with the body or the mind that's different from normal, and it is that pathology that leads to disability. In the medical model, the defect must be addressed through fixing or treating or finding a cure or preventing or eliminating the problem or pathology in the first place. And overcoming disability is seen as a return to quote unquote normal, or as close as possible as that can be achieved. The mission statement of the Children's Hospital in which I trained in general pediatrics and went on to train in developmental behavioral pediatrics was hope, care, cure. And I think that mission statement perfectly encapsulates the focus of the medical model.
On the other hand, we have the social model, and the social model of disability views disabilities as a result of societal barriers and discrimination rather than an individual impairment. And it advocates for societal changes to promote accessibility, inclusion. And so some of the focus on societal barriers include impairments, the way the society is organized and deals with them. So it includes our physical environments, our particular attitudes towards folks that have disabilities, our communication practices and the language that we use to talk about it, and then our institutional structures being the largest. It contrasts with the medical model because instead of it focusing on an individual problem stemming from a condition that's medical or some sort of impairment, it calls for changes to the actual systems that are creating the barriers for people in the first place.
A third model that we wanted to introduce today is not so much as a model as it is a paradigm. Because this presentation is part of a series supporting individuals with autism spectrum disorder, we wanted to make sure that we at least laid a little bit of a groundwork for the neurodiversity paradigm. Neurodiversity, the term, was first coined by Australian sociologist Judy Singer in the late 1990s. And neurodiversity applies to the neurodevelopmental diagnoses such as autism, ADHD, dyslexia, as well as cerebral palsy and other conditions that impact how people communicate, learn, and behave. The concept of neurodiversity recognizes that these diagnoses represent the, quote, diversity of human minds, the infinite variation in neurocognitive functioning in our species, as scholar Nick Walker writes. The neurodiversity paradigm holds that recognition, celebration, and protection of neurodiversity is essential to foster the tremendous strengths that different ways of thinking, communicating, and behaving bring to our species. In prior session, there's been some discussion in the chat about the abundant creativity and other pursuits that those with autism and ADHD find as strengths in their differences, for example. In the neurodiversity paradigm, the social model of disability, or the social framework, is used. By considering neurodivergence as a pathology within the medical model, society has failed to adapt to their differences. And in many cases, this failure to adapt and understand can be a driver for the very mental health conditions that we see high rates of in this population. Rather than spending research dollars and clinical effort in trying to find a distinct cause or causes of autism and pursuing a cure, and medical interventions seeking to help the individual be, quote unquote, as normal as possible, the autistic self-advocate community and others have used the neurodiversity paradigm to advocate for our focus in medicine and society to be on seeking to understand these differences, help to identify their strengths or their gifts, and to build systems of support for individuals and their families. Another concept that's critical to address in any discussion of the models of disability is ableism. Ableism, like all isms, represents a system of power and discrimination that values one way of existing or being over another, and thus establishing a social norm. In this case, ableism describes the implicit idea that a non-disabled body or mind is inherently more valuable than a person with a disability. I'm going to turn it over to D.R.C. Neal to tell us a little bit more about his lived experience with ableism.
The Disability and Philanthropy Forum presents D.R.C. Neal, disability rights activist.
The bottom line is that ableism is the belief in the value of a non-disabled body, and that our entire culture, all of our systems of power and production and the way that we work and make money is in relation to this. However, I would also say that ableism doesn't just come from the outside. It affected me personally and directly, because growing up as a child with cerebral palsy, a Black child, you already know you're Black. Your parents tell you you're Black, and so therefore we know that our value is lessened. But ableism then follows up with that, and it told me that I shouldn't even attempt to do better, because there were no Black disabled people that were trying to do better. When it comes to disability within the Black community directly, disabled Black people, the disability part is erased. You are basically a living ghost inside your own community. It exists, they see it, but only tangentially. And a lot of that has to do with the fact that we have not kind of taken up the mantle of embodiment the way that we've taken it up with race. It might make people angry and upset to say it, but in my viewpoint, the way I view it, embodiment supersedes race. Because how you get up in the morning and how you feel in your body does not dictate whether you're Black, white, Asian, or otherwise. And that part, the Black community just has not come to terms with. We understand that Black is beautiful, and we've spent 50 years drilling that into our children. But like when we talk about embodiment and also loving your own body, my parents hated the fact that I was a wheelchair user until I was like 25. They fought very valiantly to keep me on crutches and a walker, because to them, being ambulatory was far more important than everything else. And their argument was always, you have enough on your plate. So, instead of really thinking about it in terms of me being a whole person, it gets compartmentalized into sections, and then we start ranking. But like I said, I think that the key answer to this is embodiment. We have to take up the mantle of embodiment and put that as high or higher than race.
To continue your learning journey, visit disabilityphilanthropy.org.
Thank you, Darcy. So as healthcare providers and physicians, we hold tremendous power and responsibility when it comes to working with people with disabilities. Throughout most of history and into the present day, physicians have held the power to define, diagnose, treat, and lead the research towards cures and other interventions against these pathologies. The medical model has dictated how disabilities are viewed and what our focus is on all these interventions and on the research. What's particularly interesting for neurodevelopmental and mental health diagnoses, however, is the way that these diagnoses are created, maintained, and revised over time. With the Diagnostic and Statistical Manual, which is where the neurodevelopmental diagnoses and all, such as autism, intellectual disabilities, and then all of the mental health diagnoses that we've also discussed during this series are held. So in the DSM, we have seen dramatic changes in definitions and diagnoses as social norms have shifted. For example, I think most of you would know that homosexuality was a DSM pathologic diagnosis in editions 1 and 2. So recognizing our role, if not as individuals, at least the roles of our professional societies and our history is critical to recognizing our need to stay up to date with the changes in frameworks and paradigms so as to provide the utmost changing standards of care. And in this case, to also allow us to shift and understand these changes that are taking place in the affected communities themselves, and listen and be responsive to what their lived experience is, and how can we help make sure that we uplift these voices in our clinical spaces. I also see that William is talking about some of the changes in terminology in the chat, which is also a really important reflection. So our medical model view of disability has profound implications on people living with disabilities and their families, and are an important driver of healthcare disparities. Recent studies, whether they're 2021 and 2023, have found that 40% of physicians would rate themselves as feeling confident to be able to provide the same level of care to their patients with disabilities as those without. And only 56% rated themselves as welcoming, like actively welcoming patients with disabilities into their practice. Despite decades of qualitative research to the contrary, the vast majority of physicians report that people with disabilities have worse quality of life. And this belief and the internalized medical model that we have then leads us to, or physicians as a group, to recommend reduced support in many different life-preserving scenarios, and even to healthcare rationing and national emergencies. Like, for example, with COVID-19, we saw protocols that limited ventilator allocation to people with disabilities, for example. And then we also see that there's higher rates of overlooking related comorbidities, just like these mental health diagnoses that we've been discussing in this series. All right, so now that we've laid that groundwork, we'll move forward to some practical steps for implementation.
And as I mentioned earlier, in the social model of disabilities, some of these barriers to care that we experience here in Hawaii include relational issues of pilina and building trust, a desire to find cultural holistic health practices. Many of our people tend to be afraid to seek care because of social cultural attitudes about those who are sick or disabled. And so they're seeking specifically cultural holistic practitioners and practices. We have the linguistic, non-English speaking and pidgin, as well as barriers like medical jargon and being able to understand those different frames. A lot of cultural fear and shame and misunderstandings surrounding disabilities, which leads to a lot of intergenerational trauma. So we may have entire families that aren't seeking care one after the other. And then the usual economic barriers, which are expensive, lack of adequate, affordable insurance, time off for work and transportation, the fact that many folks care for multiple generations, not just children, but elderly and aging parents and aunties and uncles. So we wanted to offer some practical steps, including practicing cultural humility in the clinic. Some of the things we wanted to remind ourselves is we don't do any work that's using the motto of for us, by us, which means that we don't pretend to speak for anyone that's not in the positionality of the person at the center of it. We want to look at the different cultural relations and these different ways of seeing and being, this diversity of personalities, life ways. Looking at the different language preferences, which we'll get to in a slide or two. And Erika will talk about Kleinman's 8 questions. But we want to refer back a little bit to Punani Burgess and asking you, what is your name? Who is your family? What places are you connected to? And how does your family or community support you? Where are your circles of care?
I've had a lot of families when they come and share with the LEND trainees each year, and they talk about ways that being in clinic has really helped them. It's sometimes surprising. Most of them comment on taking time to ask how the family is doing and what the systems of support is. And very often when families are on our long wait list, they're calling in and asking for resources. And those resources and that support can go such a long way. Wanted to make sure that in this presentation, we touched on Kleinman's 8 questions. This is a tool from the 70s from anthropologic medical research, looking at ways that we can create a explanatory model or framework for understanding how different people from different backgrounds and cultures may experience their malady. This can be used for viral illnesses and true medical pathologies as much as it can be for mental illness and developmental disabilities or concerns. I hope that most of you have heard about or even read the story, the book, The Spirit Catches You and You Fall Down. That's one of the most famous books, I think, where they really brought out Kleinman's 8 questions and really used it to explain this experience that a Hmong family was having with their child with epilepsy. Is actually required reading in my medical school first year class, but I'd also read it in college, and I highly recommend it. But these are the questions that we can ask, and I never ask all 8, but I think over time, we can ask some of these questions, and it can be really revealing for helping us plan intervention and the approach to collaboration for working with our families. I think it's helpful even if we aren't clearly from different backgrounds or belief systems. Sometimes, these are such personal views too, that even if there's not an apparent difference, sometimes there's a different model, and it can be really helpful and illuminating. And then although we exist in the medical model, we can still affirm neurodiversity just as we've seen in the stories today. I think really focusing the autistic and disabled community talk to us about how important having a strengths-based view is. Very often in our medical setting, we're really focused on those deficits. And I find myself, especially when I'm trying to clarify a diagnosis, right? Like we are focused on that deficit. And so it's really important to then take a step back and make sure that we also identify and have families. Sometimes the families are thinking about the strengths and they're making sure that we're hearing it. But very often I find that I ask, what brings you joy with your child? What are your child's strengths? And sometimes, especially for the kids who are really struggling with behavioral disorders, it's really hard for the family to think about, and very often hard for the kid themselves to think about, especially if they've been kind of internalizing this lesser than experience, like the child in the story earlier. And so taking time to ask about that and to help bring those to light can be really helpful. Um, Supporting their voice in whatever way. Like a lot of our kids with developmental disabilities and autism may not communicate in conventional ways. And so it can be really helpful to make sure that we support them in getting access to speech therapy, to thinking about other forms of communication, augmentative communication, using pictures, drawing, typing, and making sure that the school is thinking about these things too. And of course, also giving them that space and that voice in our clinic visits. A lot of adult autistic people share that, there was this belief that they were not listening because it didn't seem like they were not listening, or that they might be intellectually disabled just because they couldn't communicate, and they were just always somewhat ignored in the clinical setting. And so trying to take time to make sure that you do address, and when you're doing your exam, like talk to the child, even if they don't seem to be responding at all, about what you're doing next and why. Promoting positive identity, recognizing that people with developmental disabilities that's affecting the neurologic system do have real sensory differences in terms of how they're perceiving sound or taste or smell, that can be heightened or lessened and can lead to a lot of distress for some people, and may lead to some of this feelings of anxiety, or may lead to some expression of hyperactivity. And so being sensitive to that and helping find coping mechanisms. I was actually taught in my fellowship to just say, well, this isn't a disorder. Sensory integration is not a disorder, and so it's not a real thing. But it actually is a real thing that really does affect these individuals' experiences. And so recognizing that and helping teach parents about that too can be really helpful. And then using strategies like that we've discussed in other sessions, like visual aids, social stories, preparing people for the transitions that are coming in the medical visit, like moving to the exam or getting your shots. Those types of things can all be helpful. And then taking time to self-educate. I've learned a lot from going out and seeking the voices of individuals with lived experience with disability, so that I understand their perspective. And increasingly, there's a lot of peer-reviewed research from the autistic and disabled communities as well. And so then we learn more, and then we can help educate the parents more too. I don't know, Mahia, did you have anything else that you wanted to add for this piece?
Not at this time, thanks.
Aha. So I wanted to conclude this session with thinking about a case that I've had in my clinic, developmental behavioral peds clinic, that we hope will draw together many aspects of what we discussed today. I have a patient who I've cared for since shortly after moving here only 2 years ago. She comes from a Samoan family, and I diagnosed her with autism shortly after meeting her. And she also has a significant language and communication disorder. She was, I think, 4 at that time. She was enrolled in DOE pre-K, and she was receiving some speech therapy, but no visual supports, no augmentative communication. And mother's primary concern was her impairment in communication. That is very frequently the main concern that a family has when they're seeing me. And then also very concerned about very significant temper tantrums and meltdowns that she was having, which were resulting in aggression and property destruction. The mom also mentioned that she was very concerned about that her child's developmental challenges were a result of choosing a name that was against her family's desires. And in her culture, the father's family chooses the name, but the mom didn't like that name, and so she had given the child a different name. And she is currently involved in legally updating her name. And so we went ahead, and in our medical system, in Epic, we can actually change a name to a preferred name. And so we did go ahead and change it there, even while she was still working on the legal pieces. Fortunately, we did successfully advocate for private speech therapy to help establish and teach her the use of AAC, augmentative and alternative communication. That can be like low tech, like pictures, picture books on Velcro, or it can be those high tech apps on tablets that you see. And sign language is also a form of communication, but we don't consider it AAC since it is its own language. Anyway, she was getting private speech therapy at Kapiolani, really taking to a high-tech tablet-based device. And when I saw her in follow-up, she was still presenting with significant signs and symptoms of autism, but she was spontaneously using her AAC device, and she was also using many more spoken words. She was communicating a lot more. Her temper tantrums were significantly reduced, and her sleep routine had regulated, which we had discussed in our visit too. As I joined the mother in celebrating all of this progress that she'd had, I asked her mom, like, what did she think made the difference? And mom reported to me that she had finally successfully legally changed the child's name. And this had led to more acceptance by her paternal family members, and also lifting of this curse, or I don't remember the exact word that she used, but this spiritual entity that was causing a lot of this challenge. So she didn't attribute it at all to the language support that she was getting.
This is where I wanted to add in. So in Polynesian contexts and different Pacific contexts, names hold a lot of power. So you may have different names at different stages of your life. You may be granted names when you take on a new role. And Mary Kavena Pukui, which is our probably most prolific 20th century Hawaiian scholar in Nana Ike Kumu, talks about the power of names in association with illnesses. So sometimes if families want to give a name and it's not given until the child receives that name, they may have an affliction. Or if they're given, quote unquote, the wrong name, a name that they're not meant to grow into, until that name is removed, like we saw here, it will affect the child's health. And more than that, it affects the relationship. So it's that pilina that we go back to. It's about how people relate to the person and how the person feels about themselves and their own identity. So the context definitely matters in a lot of the situations.
Wanted to take a couple moments then to think about language and how we talk about people with disabilities. There has been this push in medicine in general to use person first language, like person with autism, person with diabetes. And this was to push against this like depersonalization that was happening in medicine before, like kind of talking about the diabetic in room, whatever, and like really taking away from that individual lived experience. The disability community, and particularly the autism community on a whole, has really pushed back against that and have said that many of them prefer the identity first language, and that is the autistic person, or in a more medical view, like the diabetic person. And one of the most famous or prolific autistic self-advocates famously said, if I'm on a flight and my airline loses my luggage, I don't arrive without my autism. Like autism, intellectual disability, ADHD, these developmental diagnoses, these mental health diagnoses that impact the brain and the mind, like that's a part of how that person exists. And so there's really been this move towards like, this is a central part of my identity, and it's not something that I am ashamed of. It's something that is core to who I am. But not everybody has that preference. And so it can be really helpful and validating in our clinical practice if we don't know to ask. And when I'm working with young kids who haven't had that identity formation yet, when I'm talking with parents, I switch back and forth between kids with autism or kids with intellectual disability and autistic kids. Like I just kind of go back and forth throughout my language, and I talk to families about that too. Ahia, did you want to share your quote?
Oh, I added on the bottom of our slide a Hawaiian proverb in Olelo no Ea that says, "Ika olelo no keola, ika olelo no kamake." In the words are life and death, and so recognizing that words do have power, that the commands can have impacts and manifestations in the world and in how people relate to each other.
And then just this morning, Mariah Nichols, who is a disability advocate and parent of kids with disabilities on the Big Island, reposted a letter to her daughter with Down syndrome that she had published many years ago. And I wanted to highlight this quote from it. In this letter, Dear Moxie, it seems like some parents are tickled that their child with Down syndrome is acting more like their typically developing child than not. That is, when their child is growing, learning, speaking, moving, and acting as a typically developing child would at the same points in time. They don't want their child to be defined by Down syndrome. Moxie, I want you to get the memo that you have Down syndrome, and I want you to be defined by Down syndrome. You know why? Because Down syndrome gives you something that only 1 in 700 people have, your extra chromosome. The way that your extra chromosome expresses itself is a part of what makes you, you. And then she goes on to list so many positive attributes. And then she also talks about her own struggle with coming to terms with her own disabilities. And so I really encourage you, if you have an opportunity, to go look up that post.
So I really like this quote by Leilakshmi Peepsna Samarasina. Liberation will be led by the differently abled, who are used to creative solutions under the worst circumstances and with the least support. So looking at this diversity as a benefit, as our superpower, as our gifts, helps us to re-envision how we relate to each other.
We have our references in the slides that are available on iEcho. Wanted to take a couple of minutes for questions before we move into the CME questions. I saw that William put in a lot of nice comments here and then asked the question, Kleinman's 8 questions are good for older individuals, but how do you approach younger children? So I'll ask kids like, have you ever noticed anything that's different about how you act or how your brain works, how your body works compared to other kids? Some kids describe it like as their superpower, for example. That puts that nice positive spin on it. And then, yeah, a lot of times kids will start bringing that up, and then I'll say, what do you think causes this? Like, what have your parents told you, or what have you thought? Those types of questions. And yes, I agree. Parents are perhaps your best teacher. And a lot of our neurodevelopmental disabilities, like, many of them are new in this patient, especially if it's one of these more rare chromosomal or genetic disorders. But a lot of times these are heritable in families, and with changing diagnosis and social norms, like they might not have been diagnosed as kids, or they might have but grown up with like the era of stigma. And so sometimes it's been really interesting to listen to parents like lived experience with their diagnosis or self-diagnosis or strong suspicion of a diagnosis. And like I've learned more about how the stimulants affect people in real life by hearing how kids describe it and how their parents describe how their reaction to stimulants when they were younger than I ever did from the medical literature. I hope that this session gave some practical tips and tools for you. I hope that the whole series has been helpful in some ways, and I know that we will do more sessions in the future. Thank you all so much for being a part of this and for